I always give this towards the end because it is a journey into esoterica, some of which you will need to be familiar with when you take your boards. And so it's all about intractable diarrhea of infancy with the mellifluous subtitle of Insights into Molecular Genetic Pathogenesis. So instead of calling it intractable, let's call it prolonged diarrhea of infancy. I don't like the word intractable. It just sort of sounds like nothing will ever help, and that's not necessarily the case. And there are a legion of causes that you are certainly aware of. The ones in gray we've talked about previously in previous discussions. And so we're going to really be talking about those that are in bold white face type, including congenital chlorhydria, congenital sodium diarrhea, congenital carbohydrate malabsorption. And when I say congenital carbohydrate malabsorption, one diagnosis should come to mind immediately. And we'll talk about that one. And then acrodermatitis enteropathica, which we know is a problem of zinc homeostasis, microvillus inclusion disease, tufted enteropathy. We're not going to really talk much about A beta lipoproteinemia. We've done it on previous discussions, autoimmune enteropathy, and the so-called syndromic diarrhea of infancy. So all of these things for the fellows should wake up in your mind certain ideas as to what their cause is, what their manifestations are, and how they're managed. So let's break these down into specific areas of transport and talk about how those can result in intractable or prolonged diarrhea. Well, first up on the upper left, we have disorders of epithelial transport, and these are largely the result of problems with electrolyte exchange. In the case of congenital chlorhydria, it's a disorder of a chloride bicarbonate exchange. Congenital sodium diarrhea, it's a problem of sodium hydrogen exchange. And then glucose galactose malabsorption is a problem of epithelial transport of glucose along with sodium. So all of these disorders take place at the apical or microvillus membrane. And then going over certainly to panel B, there we have disorders of epithelial enzymes. And again, the most common of those being certainly sucrase isomaltase deficiency, resulting in a malabsorption of sucrose, which includes glucose and fructose, and then obviously a lactase deficiency, an extremely rare disorder that I've never seen, resulting in the malabsorption of glucose and galactose. Again, this takes place at the brush border membrane, but in this case, it's not a problem of transport per se, but a problem of enzymatic function. Going to C, we have disorders of epithelial trafficking and polarity. This is where we have the disorders of microvillus membrane inclusion disease, which is myo5B, genetically speaking, and then tufting enteropathy, which is the EPCAM deficiency, which is a problem of cell adhesion and signaling. And finally, disorders of the enteroendocrine cells, or anendocrinosis, which is a problem in hormone processing, which regulates a lot of things in the intestine, not only absorption, but also motility and transport. And then finally, we have the autoimmune enteropathies, the ones that you're most familiar with, of course, is IPEX syndrome, which is ultimately a disorder of FOXP3, a regulatory T cell homeostasis. So disorders of epithelial transport, disorders of epithelial enzymes and metabolism, disorders of epithelial trafficking and polarity, and disorders of the enteroendocrine cells, and finally autoimmune. So these are the categories of dysfunction that will ultimately lead to the infant having prolonged diarrhea. So another way to look at these is the known diagnoses in terms of what goes on in terms of crypt-villus architecture. The transport defects, those with micronutrient deficiency, enzyme deficiency, and finally congenital short bowel, and I show you the list here, generally have normal villus crypt architecture. The only thing that would affect this, of course, would be if we have secondary malnutrition, which results in villus atrophy. But under initial diagnostic evaluation, these disorders would typically have normal crypt-villus architecture. I'm not going to go down the list again. They're here for your just for you to view them, and you should certainly read more about these normal villus crypt architecture syndromes. And then we have those that are associated with abnormal villi or villus atrophy, MVI, tufting enteropathy, autoimmune, IPEX, and so on and so forth. So again, you think about how, in this case, a small bowel biopsy might help you in making the diagnosis, to divide all of these disorders into either the normal villus crypt architecture or those that are represented by villus atrophy. So let's first look at the transporter enzyme deficiencies. And they comprise four basic diagnoses. One is congenital glucose-galactose transport deficiency. The second is congenital chloroduria. The third is congenital sodium transport deficiency. And finally, we have congenital enteropeptidase deficiency. The last one, you fellows may not be familiar with, but this is a disorder of enterokinase. Enterokinase is exclusively expressed in the brush border of the proximal jejunum. It's a serine protease, and it converts proenzymes into active enzymes. So it's involved in the conversion of prochymotrypsin, procarboxypeptidases, proelastases, and prolipases into their ultimately functional forms. Now, obviously, when you have an absence of enteropeptidase and enterokinase, that may affect not only small bowel function, but also pancreatic function. In congenital enteropeptidase deficiency, these patients have chronic diarrhea early in infancy with normal villi. They lose protein, so they have hypoalbuminemia, edema, and protein malabsorption, again, for the reasons that I showed you on the last slide. Cystic fibrosis is the differential. The sweat chloride is normal. They have low duodenal fluid trypsin activity, which is restored when enteropeptidase is added. As in most of these conditions, we're dealing with an autosomal recessive inheritance. In this case, a mutation in the pro-enteropeptidase gene on chromosome 21. The treatment is pancreatic enzymes. And interestingly, these subjects, if they survive, generally have a resolution of symptoms in adulthood. That's congenital enteropeptidase deficiency. Sort of a weirder one is the proprotein convertase deficiency, which converts larger inactive hormone precursors to bioactive fragments. Proprotein convertase is found in neuroendocrine and enteroendocrine cells. Proprotein convertase 1 cleaves pro-opiomelanocortin to ACTH in the CNS, and proglucagon to GLP-1 and GLP-2 in intestinal cells. This is also very much involved in carbohydrate metabolism. PC2 cleaves pro-opiomelanocortin to melanocyte-stimulating hormone and beta-endorphin in the CNS, and glucagon in the pancreatic islet alpha cells. So if you look at experimental models of this very, very rare disorder, in null mice, they have dwarfism due to the failure of growth hormone releasing hormone production. They have bulky stools and undetectable GLP-2. In the infant with a prolonged diarrhea and this disorder, they malabsorb all formulas. They have normal pancreatic function, normal microvillus architecture and disaccharidases, elevated levels of progastrin and proglucagon, as might be expected. Proinsulin levels are high, but insulin is normal, and they have low cortisol. And interestingly enough, what starts out with malnutrition and diarrhea ends up with marked childhood obesity, as these patients ultimately adapt and they develop hyperphagia and hypothyroidism, all contributing to marked childhood obesity. I've never seen one of these. I doubt that you will ever will as well, but it's something to know about.
So this is so rare that you don't. It's probably not worth adding like cortisol and insulin to
It's. I'm sorry, but I didn't hear you distinctly, but it is very, very rare. Yes.
Okay. Thank you.
One disorder you need to know something about, despite its rarity, is microvillus inclusion disease. It is the leading cause of secretory diarrhea in the first days of life. These children are the products of high degrees of consanguinity. It's an autosomal recessive. The hallmark of the disorder is a disrupted enterocyte microvilli with a striking diminution of myosin bands attached to the membrane. It's a block in the exocytosis of PAS positive material. So what happens is the microvilli get synthesized, but they don't get inserted into their proper place, so they remain non-functional. And so you get an accumulation of a variety of glycoproteins, such as sialic acid, and these are present in secretory granules in the apical cytoplasm of the enterocytes. Sialic acid, or N-acetylneuramininic acid, is a very common glycoprotein on the MVM surface, but here it never gets there. It remains in secretory granules. And this is also associated with immunoreactivity against the buffy coat or the glycocalyx of the MVM. Its incidence is unknown, thought to be about 1 in 12,000 in United States Navajo population. There's a 2-to-1 female to male predominance. In contrast to congenital chloroiduria, which you need to know about, these patients do not have polyhydramnios. Again, MVI does not have polyhydramnios in contrast to congenital chloroiduria, where the infants do. In utero, there is polyhydramnios. There are 2 basic forms. The congenital form, no alimentation is possible. That comprises 80% of cases. There is a late onset form, even rarer, which starts in the 2nd month, where some alimentation is possible. All of these subjects have watery stools, 100 to 500 milliliters per kilogram per day when fed, 50 to 300 when fasted, and their stool sodium is typically greater than 100 millimoles per liter, which, as you all know, is a hallmark of a secretory diarrhea. They do have associated abnormalities, including Meckel diverticulum, abdominal adhesions, inguinal hernias, renal dysplasia, hydronephrosis, and absent corpus callosum. So, contrary to popular belief, this is a multisystem disease. Only the intestinal manifestations are the most obvious and clearly the most severe. It is the mutation in MYO5B, which causes microvillus inclusion disease. Homozygous mutations are found in 70%, including those from the Middle East and in the Navajo population. It's on chromosome 18. What does MYO5B do? It plays a crucial role in membrane trafficking, moving organelles towards the membrane, which is what I discussed previously. And it complexes with a family of GTPases to affect secretory vesicle transport, exocytosis, and recycling. So it really controls the secretory process. And when there is a mutation, we have unrelenting secretion. These are jejunal biopsies. These patients have villus atrophy and short crypts. You can see the positive PAS positive inclusions here. The way to think of this is these are actually the microvillus membranes that can't get up there. and that's why they stain PAS positive. D is an immunohistochemistry for villain, showing patchy linear staining of the brush border membrane and occasional intracytoplasmic circular structures, you can see here, corresponding to microvillus inclusion. So again, this is essentially a problem of transporting the microvillus membrane from its synthesis point in the cytoplasm to its destination on the brush border membrane. Again, this is a control. You can see the PAS. Here's your nice brush border membrane. And here is microvillus inclusion disease. You see the same PAS positive material, except it's now primarily in the cytoplasm because it can't get where it's supposed to be. This is immunostaining here of CD10, which is expressed in the brush border membrane. Here you can see it's all in the brush border membrane. Of course, there's some in the cytoplasm that's being transported. And here you have really sparsely in the brush border membrane, and everything is intracellular. So again, a representation of the problem in transporting the structures from the cytoplasm to their destination in the MVM. Tufting enteropathy is caused by a mutation in EpCAM, which is the gene for epithelial cell adhesion molecule. Think about what that is going to result in if there's a problem in cell-to-cell adhesion. Very rare, 1 in 50 to 100,000 live births in Western Europe. Higher prevalence in patients of Arabic origin and in areas of high consanguinity, again. No polyhydramnios, again. And other phenotypic abnormalities, esophageal atresia, choanal atresia, imperforatus. So again, this can have multiple manifestations. It's an interesting disorder. EpCAM is a transmembrane glycoprotein mediating cell-to-cell adhesion. It recruits intracellular alpha-actin to sites of cell contacts. We've talked about actin before when we talked about zonulin. Remember the opening and closing of tight junctions? And it associates with a tight junction protein, Claudin 7. Again, we discussed this when we discussed celiac disease and zonulin. EpCAM is also involved in cell signaling, cell migration, proliferation, and differentiation. So it has a ubiquitous function in the normal development of intestinal epithelial cells. And it has increased expression on the cell surface of human cancer cells and may be the target of cancer therapy. Again, problems of cell-to-cell adhesion, piling up of cells, proliferation of cells. It's not unreasonable to see why it might have increased expression in various malignancies. Its manifestations are a watery secretory diarrhea in the first weeks of life, involving the small intestine and the colon, varying degrees of villus atrophy with little inflammation. There's marked disorganization of surface enterocytes with crowding resembling tufts. And I'll show you some slides of this, which is why it's called tufting enteropathy. Is a reduction in laminin, again, is an important structural protein in the brush border. Most patients are dependent on daily, long-term TPN, and it is like microvillus inclusion disease, an indication for intestinal transplantation. So this is a schematic of the duodenal mucosa showing the histology of normal epithelial cells, that's panel A. You can see what happens in panel B with tufting enteropathy when there's problems with cell-to-cell adhesion, how the cells become crowded and piled up on one another. In panel C, you see stained duodenal tissue from actual patients. So the best thing to do is look at B and look at how this is represented here, and you really see the same thing here. These are the so-called tufts, which are the result of the piling up of epithelial cells because of the mutation in EpCAM, which affects cell-to-cell adhesion. Again, jejunal biopsy, severe villus atrophy, moderate crypt hyperplasia. And here, I said there was a little mononuclear infiltrate. Now, this is later on. There's a marked mononuclear infiltrate here. And here we have the surface tufts at the tips of the blunted villi. Of these, if you take these individual cells, the microvilli are normal. But because these cells are piled up on one another, with the microvilli pointed every which way, you really have problems, not only in secretion, but also in absorption. And this is an ultrastructural picture of desmosomes, which are increased in length and number. Here are your desmosomes, which comprise the tight junctions. And as you can see, again, how this could affect cell-to-cell adhesion and cell migration. For those of you who are interested, Bryce, I know you're interested in this stuff. If you look up Olivier Goulet, he's done most of the work on this and is worth reading. And here's again that long desmosome between cells.
Thank you.
Again, desmoglian, which looks at the desmosomes. You can see here how florid it is, and it's all over the place. Again from Olivier Goulet, typical disorganization of the surface enterocytes with crowding forming these tufts. Now, we've talked about enteroendocrine cells. We're not going to talk a lot about this. Remember that the enteroendocrine cells looks like the Paneth cell, except what's the difference? Well, the difference is the marked eosinophilic material in the Paneth cell is pointed towards the lumen. The eosinophilic material here is pointed towards the circulation. This is the enteroendocrine cells. All right. So this is the normal on the left, and on the right you see none of these enteroendocrine cells. And here's another way. This is a chromogranin A immunohistochemical stain, which really shows you in the marked contrast between the normal and the anendocrinosis over here. And if you look at enteroendocrine cells over a group of patients, normally you have 145 and amino 50 crypts. In those with enteroendocrine cells dysgenesis, you have very little. So, how do these cells develop, and what is the normal pathway for intestinal cell production in the GI tract? Well, it all starts with our friend beta-catenin. Remember, we talked about beta-catenin when we talked about polyposis syndromes, and how beta-catenin was really one of the signaling molecules responsible for cellular proliferation. So beta-catenin will stimulate a progenitor cell, and then we engage in what's called Notch signaling. We talked about Notch signaling, and this is a genetic signal that is conserved straight through the phylum from the fruit fly up to us. And it all depends upon whether there's a strong level of Notch signaling or a low level of Notch signaling. If there's a strong level of Notch signaling, and I'll show this in greater detail on a subsequent slide, we end up with absorptive enterocytes. With a low level of Notch signaling, those cells which may manifest the Notch ligand instead of the Notch receptor, depending upon what transcriptome they're influenced by, they can either go to form goblet cells, Paneth cells, enteroendocrine cells, or if influenced by another neurotransmitter, neurogenin 3, we go on to the pancreatic islet cell. So let's look at this in a little bit more detailed or a figurative way. Here we have the intestinal pluripotent stem cell, right? and then we have initially high Notch signaling. If that high Notch signaling remains, we end up with the absorptive enterocyte. If there's less of that Notch signaling, we go to a different class of progenitor cells and wind up with the enteroendocrine, goblet cell, tuft cells, and Paneth cells. So all of these cell types in the intestine and in the pancreas arise from the same precursor stem cell. In enteric endocrinosis, how does the absence of these cells induce malabsorption? Well, think about what hormones control in the gut. Motility, peptide YY, the ileal brake, the overall tone of the GI tract. They control biliary secretions through cholecystokinin, pancreatic secretions called CCK and secretin. And endocrinosis will give you an absence of endoproteases. We talked about enterokinase deficiency, and also cause an absence of epithelial growth factors. So you can see how this absence of a single cell type will have pluripotent effects on multiple GI and pancreatic functions. Autoimmune enteropathies. There are three major types: IPEX, APOSED, and autoimmune enteropathy. IPEX syndrome involves immunodysregulation, polyendocrinopathy, enteropathy. It is X-linked, else that's why it's called IPEX. Right. APOSED syndrome is autoimmune polyendocrinopathy, candidiasis, and ectodermal dystrophy. I've seen IPEX syndrome several times, never seen APOSED syndrome, and I've certainly seen autoimmune enteropathy. First off, autoimmune enteropathy is marked by total villus atrophy, crypt hyperplasia, obvious on this slide, and marked mononuclear cell infiltrate in the lamina propria. If you look at their antibody profile, their systemic IgG complement fixing antibody is elevated. These antibody levels decline or disappear in response to immunosuppressive therapy. IgG subclass 4 is typically elevated in some, but not in all. If you get an autoimmune enteropathy patient on the boards, they will certainly tell you that the IgG subclass 4 is elevated, which is going to be the tip-off for autoimmune enteropathy. And they'll ask you what the therapy will be, and you will say the therapy is corticosteroids. That's the board question. How would you next manage the patient? And the answer would be corticosteroids. IPEX syndrome, something you clearly have to know about. These are the problems associated with IPEX: intractable diarrhea, eczema, diabetes, failure to thrive, thyroiditis, and ultimately hypothyroidism, hemolytic anemia, thrombocytopenia, recurrent infections, and also kidney problems, particularly membranous nephropathy.
The diarrhea and IPEX can present like IBD, by the way.
Yeah. Mm-hmm. And again, this is the clinical manifestations in this series, where enteropathy and diabetes were the ones that were the most prevalent, but all of these were significant. And if you look at indirect immunofluorescence for autoantibodies in the patient's serum with IPEX syndrome, bright staining of the brush border on the intestinal epithelial cells is found not only there, but in the proximal tubules of the kidney. Serum from an IPEX patient reacts with goblet cells on the duodenal and colonic mucosa, you see here on the bottom panels C and D. So this is an autoimmune phenomenon. And what causes IPEX syndrome? You have to know this. It's a mutation in the FOXP3 gene. FOXP3 is located on the X chromosome. It regulates development of CD4 positive and CD25 positive naturally regulatory T cells. These regulatory T cells limit the immune response of other T cells. FOXP3 binds to the nuclear factor of activated T cells and prevents its binding to transcription factors that induce genes involved with T cell, T helper, or T killer cell activation. There have been more than 20 mutations identified in patients with IPEX, and a few patients without FOXP3 have been demonstrated, but that's really not important for you to know. You have to know that this is a problem. Distill it down to its simplest format. Disorder of FOXP3. FOXP3 is the central brain controlling the production of regulatory T cells. And here, FOXP3 regulates NFAT-mediated gene transcription to CD4 and CD5 regulatory T cells. This is a schemata that shows that. Upon T cell receptor stimulation, NFAT binds to an activator protein, AP1, in conventional T cells, but to FOXP3 in CD4, CD25 positive regulatory T cells. And depending upon which way you go, if it binds to FOXP3, you have T cell suppression. If you bind to AP1, you have T cell activation. So it's all about a balance between the two. How do you diagnose IPEX in terms of its clinical symptoms and laboratory findings? These patients have a flat villus lesion with intense inflammatory infiltrate. They have watery and at times bloody diarrhea. So this is the one prolonged diarrhea that is going to be bloody in nature. They also have early insulin-dependent diabetes, demonstrating autoantibodies to islet cells. They develop hypothyroidism. They will have an elevated TSH and antithyroid antibodies. In terms of skin manifestation, eczema is the most common. They also may have a psoriasis-like lesion, urticaria, a pemphigoid, and also develop alopecia. They often have elevated levels of immunoglobulin E and demonstrate eosinophilia. It's a very unique set of clinical manifestations that you should be able to recognize. Now, again, not to belabor the point, but this is, again, IPEX, a rare genetic autoimmune disease due to mutation in the FOXP3 gene, which is a key molecular factor driving T cell tolerance because of the stimulation and the production of regulatory T cells. Enteropathy, dermatitis, endocrinopathy, elevated immunoglobulin E, leading to the obvious, quote, allergic, end of quote, manifestations, hematologic abnormalities, renal, hepatic, lymphadenopathy, autoimmune. So all of these are represented in IPEX, and certainly a multi-system disorder. APOSED is autoimmune polyglandular syndrome type 1. Its classical presentation is hypoparathyroidism, hypoadrenalism, and chronic mucocutaneous candidiasis. They also have autoantibodies that can affect the gonads, thyroid, liver, pancreatic, B cell, beta cells, and gastric parietal cells. And they have dystrophic dental enamel, dystrophic nails, and alopecia. They do have diabetes, but at a much lower rate than the IPEX syndrome. And they also may develop autoimmune hepatitis. The mutation is in the autoimmune regulator gene, which is expressed in thymic epithelial and dendritic cells, and allows escape of autoreactive T cell clones from the thymus that engage in multiple autoimmune manifestations. If you look at APOSED and autoimmune enteropathy, again, seen in 10% of patients who also have autoimmune enteropathy. And this is a rare disorder associated with antitryptophan hydroxylase and antihistidase decarboxylase antibodies. They're decreased or absent serotonin producing cells, decreased histamine-producing enterochromaffin cells, and decreased or absent enteroendocrine cells. So these patients may actually present with patients with anendocrinosis. Finally, we have syndromic or phenotypic diarrhea in early infancy, also known as the trichohepatoenteric syndrome. At early onset, severe diarrhea requiring parenteral nutrition. Here, 1 in 300,000 live births. Again, parental consanguinity has an unknown etiology. Half of these patients have hepatic fibrosis or cirrhosis with increased iron deposition. So it is one of the manifestations of neonatal iron storage disease. And this is a result of functional T-cell immune deficiency. The clinical manifestations are small for gestational age, dysmorphia, and they may have frontal bossing, prominent cheeks. Actually, I'll show you a couple of pictures is worth 1,000 words. Facial dysmorphism, prominent forehead and cheeks, broad nasal bridge, and hypertelorism. They have very woolly hair, which is easily removed and poorly pigmented. Again, Olivier Goulet, who's sort of the king of these weird prolonged diarrheal syndromes of infancy, has written the most on this. These patients have variable histology from something that looks fairly normal. This is certainly blunting, but there's no crypt hyperplasia, to a situation where you have total villus atrophy. And this is the microscopic analysis of the hair shaft showing this brittling effect. Acrodermis dendropathica, another board favorite shown here. These are children who present with this typical scaly, wet eruption, perioral, perianal, typically. And this is a problem of ZIP4 expression, looking at the tissue distribution of ZIP4, and the ZIP4 typically localizes to the apical membrane of the enterocyte. When it's absent, you have a problem in the absorption and metabolism of what heavy metal?
Zinc?
Zinc, right. So this is, in the end, a disorder of zinc metabolism. Save the best for last, something that's always on the boards, congenital chloroduria. This is a rare autosomal recessive disorder, mutation in the SLC26A3 gene. This is a defect of intestinal chloride bicarbonate exchange. If you get a case on the boards, you'll always have a situation of maternal polyhydramnios. That is typically the tip-off. And these patients have a persistent chloride-rich secretory diarrhea from birth. They present with a hypochloremic metabolic alkalosis. Their stool chloride is greater than 150 millimoles per liter and is typically greater than the stool sodium. So there are other cations which are secreted along with chloride, not only sodium. So here we have the differential diagnosis of prolonged diarrhea of infancy. So it's shown here. We've gone through a lot of these. What are you going to do? How are you going to differentiate? How are you going to work these patients up? So let's talk about, for the remainder of the time, the evaluation of the infant with chronic or intractable diarrhea. So let's look at this for a while and see what happens. And for those of you who are interested, and you should all be interested, there is the citation on the bottom. This is a seminal article on this problem and worth reading. So, red flags. Polyhydramnios. We talked about the disorders associated with that. Consanguinity, and then after birth, multi-system involvement. So we get a history, age of onset, family history, ethnicity, and prenatal history to try to figure out what these red flags are. So What if they have neonatal onset or red flags present, usually in the hospital, requiring clinical care? All right. What are the disorders? A congenital enteropathy of some point, of some nature, major anatomic abnormalities, or necrotizing enterocolitis. All right. If you're suspecting a congenital enteropathy, you have to evaluate the diarrhea type. Through stool testing, is it bloody, IPEX syndrome? Is it fatty, A-beta lipoproteinemia maybe? Or is it watery? Let's talk about congenital chloroduria, microvillus inclusion disease, all right? So this will give you a key of where your workup is going to go next. Are there major anatomic abnormalities? If you suspect that for some reason, obviously imaging studies. And of course, NEC in the proper clinical setting, you're all familiar with. So what are the typical tests you're going to do? Blood tests, CBC, electrolytes, albumin, enzymes, CRP, ESR, IgG, cholesterol, of course, and the stool tests, stool electrolytes, extremely important. Stool for reducing substances, extremely important. Fecal elastase, fecal fat if you can get it. Fecal alpha-1 antitrypsin for protein loss. pH, and you can also look at fecal calprotectin or lactoferrin, although elastase is probably lactoferrin or calprotectin. Probably Dr. Wallach will tell you you have to look at the mitochondrial proteins produced. So
protectin in like breastfed infants can be a little unreliable too.
Yes. But Calpro can be, So the rationale for electrolytes, this is a key test evaluating the nature of the diarrhea and for calculation of the stool osmotic gap, right? We all know the stool osmotic gap, if it is normally, the stool osmotic gap is 290 minus 2 times the sum of sodium plus potassium, all right? A stool osmotic gap of greater than 100 milliosmoles is defined as high and usually means there's some other solute there, typical in malabsorption syndromes. Less than 50 milliosmoles is defined as low, and that is typically what we see in a secretory state, and the gap is somewhere in between. What about reducing substances? Well, that is going to indicate the malabsorption of monosaccharides. A low pH results from an abundance of short-chain fatty acids that are the products of fermentation and are indicative of carbohydrate malabsorption. Alpha-1 antitrypsin, protein loss. Fat, we've talked about that. Elastase is unchanged by intestinal proteases and can imply pancreatic insufficiency. Problem here is that it may be diluted and reduced in high-volume chronic diarrhea. Tom, does mitochondrial DNA affected by diarrheal state at all?
Anything can be diluted by diarrhea.
Anything can be diluted. So when you have somebody who's in a diarrheal state, some of these tests are less reliable. Of course, tests for occult blood and inflammatory markers in infectious studies. So again, diarrhea type. If it's fatty, go first to stool elastase. If it's abnormal, cystic fibrosis, Shwachman-Diamond syndrome. Normal elastase, maybe A-beta lipoproteinemia, or some other strange disorders. If the diarrhea is bloody, a very early onset, inflammatory bowel disease, IPEX syndrome, autoimmune enteropathy. Watery diarrhea. Well, this is the one that's going to be the most difficult because this is where you have to suspect, is this a product of carbohydrate malabsorption? Well, these patients are going to improve on a fasting trial. And then you adjust their diet to see whether the diet adjustment is going to result in improvement. Again, here's the citation. I urge you to go look at it and study this. If you do not suspect carbohydrate malabsorption, The next line is going to be endoscopic biopsy, looking for abnormal or normal villus architecture. If it's normal villus architecture, does the patient have hypoalbuminemia, edema? Is alpha-1 antitrypsin positive? Could this be, for instance, intestinal lymphangiectasia? If there's no improvement with fasting, could this be an abnormality of electrolyte transport, congenital chloroduria, congenital sodium diarrhea, hormone diarrhea, the result of endocrinosis, abnormal villus architecture, epithelial structural defects, tufting enteropathy, MVID. Here, of course, we're on the arm of the workup where these patients are clearly going to require transport to not only an intestinal rehabilitation center, but to a center that can engage in intestinal transplantation. Because these patients with tufting enteropathy and MVID will generally not survive without a transplant. So, again, it all boils down to SI histology, normal villus crypt architecture versus villus atrophy. That can give you all of the essential information you need to know. So that small bowel biopsy certainly becomes extremely important in this group of disorders. And finally, we talked about what is the prevalence of these disorders, where do you see them? This is a series of 60 patients with intractable or prolonged diarrhea, published in 2014 in JPGN. Surprisingly, to me, the most common known disorder was glucose-galactose malabsorption, was the carbohydrates malabsorption, which include 6 with glucose-galactose malabsorption, 3 with congenital lactose intolerance, which I find unusual, and 2 with unclassified carbohydrate malabsorption. So again, this was a very prominent group. We have 11, 17, 20, 22 out of 60. So these are patients who might be expected to improve with diet alteration. Oh, excuse me. And here you see the other disorders. Keep in mind that of the 60 patients, 16 had an undefined etiology. So this is a lot of information. I think I've pointed out the essential references that you need to look at, especially this one from gastroenterology and hepatology, which I think gives you a very nice algorithmic approach to the infant with prolonged diarrhea. And that is the end.
Thank you.
Thank you, Dr.
Steve.
Schwartz.
You are very welcome. Let me stop sharing.